Hello, and thank you for joining us for this very special Africa webinar. Wherever you are in the world, welcome to this very important conversation. We're very pleased that you're with us today, and I'm looking forward to a great hour and a half with you. My name is Anne Soy. I'm a health journalist for Africa based here in Nairobi. And I have a little announcement. So if you are English speaking, you don't need to do anything, you just need to continue. But if you're French speaking, si vous souhaitez écouter en français, il y a un bouton en bas de page appelé interprétation. Cliquez dessus pour la traduction. So that's the translation for French. There's a button at the bottom if you need the translation in French. Right, now our webinar today is hosted by the Drugs for Neglected Diseases Initiative, DNDi, and the COVID-19 Clinical Research Coalition. DNDi develops urgently needed treatments for neglected patients and works to ensure they are affordable, available, and adapted to the communities who need them. Since 2003, DNDi has developed 8 treatments for 5 deadly diseases and works in countries throughout Africa. DNDi co-launched the COVID-19 Clinical Research Coalition in early April 2020 to help fast-track desperately needed research for low-resource settings. More than 250 member representatives from 168 institutions in 56 countries have joined and are working to complement their efforts and the efforts of the World Health Organization and other stakeholders in researching new tools for COVID-19 prevention, diagnosis, and treatment in resource-limited settings, particularly here in Africa. So first of all, just some housekeeping. We are streaming on various platforms that includes Twitter, YouTube, Facebook, and we welcome your comments. Please let us know if you're following us, where you're following us from. We might just mention your name, and also keep sending your questions. We have an excellent panel of experts, public health leaders from different countries here on the continent. Our hashtag is #Africa COVID-19. Please keep tweeting #Africa COVID-19. And as I mentioned earlier, there's interpretation for French speakers. So if you don't understand anything that I'm saying, if you speak French, there's a button for you at the bottom of the page. I will have a question and answer period at the end of this webinar. But first of all, today's webinar focuses on a highly topical issue: responding to COVID-19 in Africa, the myths, the lessons, and the future. At the start of the COVID-19 pandemic, the African continent was referred to as a ticking time bomb. Analysts and commentators were worried about the health systems in Africa and whether they could cope in such a big outbreak. But so far, months later, we are seeing that much of Africa has averted the worst predictions. So how was that achieved? We have experts to talk about that today. Particularly the high death rates that we are seeing in other parts of the world, that has been different here in Africa. And so they will be explaining to us this afternoon what is going on. So the next 90 minutes, follow this discussion and contribute as well. We'd like to hear your questions. We'd like to know that you're following us on our various platforms. So start sending your messages now. I would like to introduce a very short video just to set the stage for our discussion this afternoon. As you can see, we have a brilliant lineup of public health experts from different parts of the continent, as I promised. And Dr. John Nkengasong, who has been steering and bringing countries together to try and have a unified approach to dealing with COVID-19, is here with us. He will be giving the keynote speech. I will introduce him later on. But first, from South Africa, we welcome Professor Helen Rees, the Executive Director of WITS Reproductive Health and HIV Institute, that's WITS RHI. Helen has notched up several awards for her work, no doubt, and is internationally renowned for her research and policy work in HIV, vaccines, and reproductive health. She's leading the South Africa part of global trials for COVID-19 vaccines and is on the steering committee of the COVID-19 Clinical Research Coalition. Professor Rees, just say hello to our audience this afternoon.
Hello, everybody. I look forward to talking with you.
Thank you very much, Professor. And joining us as well from East Africa, I'm very pleased to welcome Dr. Borna Nyaoke-Anoke. She's the Senior Clinical Project Manager and Medical Manager at DNDi. Borna managed the first ever phase 2 clinical trial for a new treatment in Sudan, part of the neglected diseases work that DNDi is doing. She has expansive experience in clinical research with previous work in clinical trials for HIV and Ebola vaccines. Dr. Borna, please say hello.
Thank you, and hello, everyone.
And from Central Africa, we have we want to have Professor Jean-Jacques Muyembe, and he was really looking forward to be with us. He had even tweeted about it. Sadly, as we all know, he is very, very busy. So he has other travel engagements, so he couldn't join us this afternoon. But in his place, we have the very able Professor Steve Mundeka Ahuka, who is the incident manager for COVID-19 in the DRC, the Democratic Republic of Congo. He was also the incident manager for the 10th Ebola outbreak in the DRC. Professor, if you're with us, please say hello.
Hello to everybody.
Merci, Professor. Professor Ahuka is a senior researcher at the National Institute for Biomedical Research in Kinshasa. And he's a professor also of microbiology at the University Clinics of Kinshasa, the Faculty of Medicine at the University of Kinshasa. And now to our keynote speaker, Dr. John Nkengasong. Very pleased to have you with us, Dr. Nkengasong. He's the director of the Africa CDC, an African-owned institution that supports countries to improve surveillance, preparedness, and response to disease threats. Dr. Nkengasong is a leading virologist and has been at the helm of the Africa CDC since its formation in 2016. He has received several awards for his outstanding work in public health. Most recently, the Bill and Melinda Gates Foundation awarded him the 2020 Global Goalkeeper Award for his work in response to COVID-19. Welcome, Dr. Nkengasong.
Thank you, and good to see you again.
Fantastic. Just to start us off, Dr. Nkengasong, Africa has been praised for an effective campaign against COVID-19, and you have been bringing countries together to work together. So what is it that has worked for African countries, and what challenges are you experiencing?
So thank you, and let me
We can see your presentation is up, Dr. Nkengasong. Please go ahead.
Okay, good. So let me, and in the next couple of minutes, share with you some of our Okay, continue. So if I may just have the next slide, please. I understand the control is from that side. Good. So this slide you see in front of you gives you an update of where we are with the pandemic in Africa as of today, the November 2nd, where 1.7 million cases have been recorded in Africa, of which 1.4 million have recovered, representing 82%, and 43,000 people have unfortunately died, which is represents a case fatality ratio of 2.4%. The curve you see on the right-hand side shows you how the pandemic has evolved. And if I may just ask for the next slide, please. It's an animation. Just yes, thank you. And it shows that it took us 133 days to get to 500,000 cases. And then the pandemic gained speed, and it took us only 30 days to move from 500,000 cases to 1 million cases. And then it slowed down a bit, where it would require another 58 days before we move from 1 million people who were infected on the continent to 1.5 million. Next slide. The curve you see in front of you here represents a 7 days moving average since the pandemic started. And if you just click on that slide a little bit, next slide, it shows you, next one, it shows you that at the peak of this pandemic, as a continent, we were recording about 18,000 cases per day. Next slide. And next. And then as the pandemic stabilizes, we started looking at, we had a drastic reduction in the number of cases, daily cases, and then started recording about 7,000 cases a day. If you look at the very tail end of this curve, it shows you that our numbers have ticked up slightly, and we now have about 9,000 cases a day. So I think we have to be very, very vigilant here and take this ticking up or a slight increase very seriously. Next slide. The reason we have to take that seriously is that Europe is going through the second wave. And if you look at these graphs carefully, the first wave of COVID-19 in slide, please. I really wish I was doing this myself. Was around April, and we had, Europe was reporting about 37,000 cases. Next slide. And around October, the second wave has hit, and Europe is recording about 150,000 cases a day. So next slide. As a continent, we have to be very, very careful and learn the lessons from Europe and prepare ourselves for any potential second wave. We are better prepared today than we were 10 months ago because we have more diagnostics, we have more personal protective equipment, we have more understanding of how the virus is transmitted and how we can prevent ourselves. I will now walk through the 5 regions of the continent so that you see how the curve has changed over time. One, this is the Central Africa region, and this is the period between August 18 and October 18. And you can see clearly that Central Africa had a first period where there was a drastic decrease from August by about 53%. And it slowed down a little bit, but still in a decreasing mode of about 18%. Next slide. Then East Africa shows a different picture. It also peaked around August, and it had a drastic reduction of about 50% in East Africa. But as you can see, it is beginning to creep back up about 36% in new cases. That is between August 18 and October 18. Next slide. Then in North Africa, you see that there's been a steady increase in the cases, percentage changes in new cases over the last 4 weeks. And I think that is a sign that that region needs to continue to increase its public health measures to try to control the pandemic. Next slide. And then Southern Africa, where you can see that because of the tremendous efforts that South Africa did in controlling the virus, the overall trend has been extremely favorable, with a rapid reduction in the number of cases of about 51%. But you can see that there's been a slight creeping up. If you look at the very tail of this curve, it shows you that about 0.5% increase have occurred over the last couple of weeks. Next slide. Then the testing. This slide shows you that clearly that, I mean, our testing has increased. We've tested as a continent cumulatively about 18 million tests conducted. That has resulted in a test per case ratio of 10.5% with a positivity rate of 9.5%. The different lines that you see here just represent the different regions where the testing, how the testing have played out in the different regions. Next slide. And this slide shows you that a summary of the distribution of the test per case ratio across the continent. 21 countries are reporting less than 10 tests per case. 25 countries are reporting about 10 to 20 tests per case. 7 countries are reporting 31 to 100 tests per case, and 2 countries are reporting more than 100 tests per case. So the overall testing across the continent has significantly increased. However, there are some countries that are still lagging behind. Next slide. So to continue to improve that gap, technology is improving. As you can see on this slide, we did launch an initiative with the WHO, represented here by Dr. Tedros, with the FIND, Foundation for Innovative Diagnostics, the Global Fund, and myself a few weeks ago, where the goal is to roll out more than 120 million antigen tests. The antigen test will be able to give you the similar results like the PCR testing, because it measures the effect that the virus is replicating. So I think we are very excited with this because it will be rapid, it will be easy to perform, and it will allow that we decentralize the testing as quickly as possible. Next slide. Now, with respect to the continental strategy, where Anne asked the question, what did the continent do? I think the continent brought itself together very quickly. This slide shows you a meeting that Chairperson Musa Faki convened on February 22nd in Addis Ababa, where all ministers of health were invited to come so that we look at the continental strategy and endorse it. Next slide. And that strategy has been a cornerstone for our response continent-wide, and the ministers endorsed it in February 22nd. The Bureau of the Head of States endorsed it on March the 26th. So it has since become a joint continental strategy. Next slide. And the strategy has 3 pillars. One is the prevention, and second is preventing transmission. The second pillar of that is preventing deaths. And then the third pillar is to prevent social and economic harm, and which means harm to both economy, other diseases like HIV, malaria, and TB that are already challenging us, including immunization programs. Next slide. Next. So a task force was established called the African Task Force for COVID-19, and which is underpinned by the need to coordinate, cooperate, collaborate, and communicate. And what you see on your left-hand side are the different technical working groups that make up the task force. And this task force convenes every Tuesday at 4 p.m. in Addis Ababa from my Emergency Operations Center and connect with the continent so that we can discuss and strategize on how to continue to battle the virus. Next slide. As part of that strategy, we developed what we call the Partnership to Accelerate COVID Testing, in abbreviation PACT, which was underpinned by the need to increase the testing, tracing, and treatment. We initially set ourselves a target of about 10 million tests to be conducted before October. And we also wanted to be sure that we had a common platform for procurement, as you see on the slide on the right-hand side, and then to deploy 1 million community healthcare workers that would support the response effort across the continent. Next slide. And this platform is part of that strategy, the PACT strategy, where we now have what we call the African Medical Supply Platform. And you can Google that on amsp.africa, and you'll be able to see exactly what commodities, COVID-19 response commodities, including diagnostics, that can be accessed from the platform. And this platform was developed under the leadership of Stripe Masiyiwa, who is the Special AU's envoy, nominated by the President of South Africa, His Excellency Cyril Ramaphosa, and is also a good example of innovation and partnership with the Afro-Exim Bank and the United Nations Economic Commission for Africa, UNICA, and Africa CDC. Next slide. So let me just use this slide to transition to vaccines. What are we doing in the area of COVID-19 vaccines? We just recently published a paper in Nature where we argued that history slide must not repeat itself, and we need a global and continental cooperation strategy to ensure that Africa has access to vaccines, that is COVID vaccines, once they become available. Next slide. Next, please. And why did we insist on? So this is a strategy that, if you can just go back to the previous slide, please, it's important. Yeah, this slide shows you clearly that in 1996, if you look at the gray bar carefully, drugs against HIV treatment were available. And if you look at the blue line carefully, the rate of people that were infected with HIV and were saved from the drugs decreased significantly. That is, the AIDS-related deaths in the United States decreased. But if you look at the red line shows clearly that the death rates increased in Africa for almost 10 years. And between that time, that is between 1996 and 2006, about 12 million Africans died because of lack of access to AIDS-related drugs on the continent. And this is a lesson that we truly don't want to be repeated. Next slide. So we have now developed a continental strategy for vaccine, next slide, and submitted to the Bureau of the Head of States, which was endorsed on the 20th of August. Next slide. Next. And again, no, go back to the previous slide, please. So if you look at this carefully, the last sentence there says, the head of states and government stressed that Africa should take appropriate measures as part of the strategy to ensure that it secures timely access to COVID-19 vaccines when they become available. Next slide. So I'll just, through a few slides, go through some part of the strategy, which has 3 goals. The first goal is to make sure that Africa participates in vaccine clinical trials. The second goal is to ensure that we have access to sufficient doses of the vaccines. And then the third goal is to remove barriers to vaccine deliveries and uptake in Africa. Next slide. So this slide just shows you the first goal, where Professor Slim Karim and Professor Sabaso from South Africa and Mali, respectively, are co-chairing the COVAC, which is the Consortium for Clinical Trials pillar. And we've made a lot of good progress in that area. Next slide. And this slide simply shows you the number of clinical trials that are going on in Africa, and also sites that are ready to go if any company was available to work with us to introduce clinical trials on the continent. The red dots there show sites that trials are taking place, and then the dark dots there indicate capacity that is available on the continent. So you can see that there's excess capacity available on the continent to support multiple clinical trials for COVID-19 vaccines. Next slide. So with respect to the second goal, which is to access sufficient quantities of vaccines, we know that countries are adhering to the COVAX facilities in Geneva, which is supported by Gavi and WHO. You also have the second option where we are pursuing with manufacturers to develop an initiative that will be supported from the continent to supplement the COVAX facility. Next slide. So this slide summarizes for you the total needs that are required. We believe that it will take us, it required us that 60% of our population is immunized to achieve herd immunity. And if we're a population of 1.2 billion people, we believe that about 1.5 billion doses of vaccines will be required, and will cost about 10 to 15 billion in terms of purchase and delivery. Next slide. So we also know that WHO has promised that about 220 million doses of vaccines will be available. And if we look at you factor in 10% waste, and then you consider that 2 doses of vaccines are required per person, it actually would give us, it leads to immunization of about 100 million people. Next slide. Which will represent about 8% of our population. So we have a big gap there to finance for vaccines across the continent if we work in partnership with COVAX, WHO, Gavi, and CEPI. Next slide. So let me now transition to what we are seeing on the continent in terms of lockdown. This map shows you the different levels where countries are with respect to easing the lockdown on the economy. Next slide. We have now launched an initiative called Africa Against COVID-19, Saving Lives, Economies, and Livelihood, that requires the whole of society approach. That way we can protect our borders and travel, we can protect economies and livelihood, and protect schools, because we recognize that we have to have a balance between livelihoods, saving lives, and saving our economies and schools. Next slide. So this initiative was launched on October 5th in Addis Ababa, and we now have an Africa CDC trusted travel portal where you can actually go in, click in, and you see all what is required if you need to travel to a different country. So if moving from country A to B, and you go to My COVID Pass, for travelers, you can actually see exactly what is required on the other side of the continent, and there's mutual recognition across the board. Next slide. Let me just conclude on this slide, which is what do we need to do to maintain the gains that we have seen over time and prepare for the second wave. The first message is there's absolutely no room for complacency, no prevention fatigue. We must intensify public health and social measures against COVID-19, and we need political leadership to do 5 key things. 1 is to enhance community engagement for improved usage of face masks and hand washing measures. 2nd is to avoid large gatherings and crowded events. 3rd is to make sure that we continue to scale up the partnership to accelerate COVID testing pack, that is the test, trace, and treat. Thirdly is to enhance our surveillance. It is through enhanced surveillance that we will be able to pick up pockets of infections or hotspots that will emerge because as we ease the lockdown on the economy. And lastly, continue to ensure the adequate supply of personal protective equipment. Next slide. I thank you all for your kind attention, and over to you.
Thank you very much, Dr. Nkengasong, for the very clear presentation. It's always a pleasure listening to you because we learn so much. No room for complacency, as you say, and the need for political leadership. We saw that come into play earlier this year, and as you say, we cannot afford to have prevention fatigue right now, considering here on the continent we have at least 6 elections before the end of the year. That means large crowds. No doubt we need a lot of political leadership to prevent a major disaster. Thank you so much, Dr. Nkengasong. So next up, we'll have Professor Helen Rees to give us an overview of what's going on from the research front. You know, people have been waiting and, you know, just waiting to hear from scientists like you, what's going on in the research space? When can we have a vaccine? What is Africa's contribution to that? And this is, you know, some of the work that you are involved in. And just to our audience, keep tweeting about it, hashtag Africa COVID-19. Keep sending us your message. The questions are already coming in. Keep sending them. Let us know where you are, who you are, and ask the question. And if you would like to follow in French, we have interpretation. At the bottom of the page, you should see a button called interpretation. Il y a un bouton au bas de la page appelé interprétation. Cliquez dessous pour la traduction. We have translation in French. Thank you so much. So Professor Rees, you're involved in some of the COVID-19 vaccine research. What is going on the continent in South Africa where you are? And as a journalist, I must ask this, when can we expect a vaccine?
It's the million-dollar question that we'd love all to be able to answer, I think. The sooner the better would be the answer, but not at the cost of good science and safety. So we're trying to balance going as fast as we can with maintaining all of the standards that we require to demonstrate whether or not the vaccine is effective and whether it's safe. So we think that at the earliest we might get some data at the end of this year indicating on some of the most advanced clinical trials. We've got 10 now and over 200 that are in development. We're hoping that that's when we'll start to hear. But in truth, when will we get a vaccine? And I'm going to pick up on what John says. I think that we think that if we're lucky, we will get some vaccines manufactured and available towards perhaps the first and second quarter of next year. And perhaps by the middle of next year, we would be starting to see amounts manufactured that we could start to use at a country level. We will not have enough vaccine for everybody then. We still will have to wait for a much longer period to have sufficient vaccine for all the populations in our countries that we want to offer vaccine to.
And Professor, questions are coming in. I can see one from somebody is asking in the United States, they would want to participate in trying to get some of their diagnostics and vaccines. How can they contribute? We will come to the question and answer period, but just very fast, what do you have to say to this person who's willing to contribute to the work that's going on?
I mean, it depends what they mean by contribute. If they're in a place where there isn't a vaccine trial, for example, available, and so they can't volunteer for it, and perhaps they're not in an age group or a category that's suited for that trial, then one of the things that we would really, really encourage people to do is just to talk about the importance of vaccines. There's a lot of misinformation out there, but we know, looking at the epidemiology, that unless we actually start to focus on getting a vaccine to complement immunity that's been generated through the wild infection, the wild virus. Unless we can do that, we're not going to be able to stop this. We're going to see this virus going round and round and round and coming back repeatedly. So talking about it and advocating for vaccines is one thing. If you are in a situation where you can volunteer to be a vaccine participant, we would also suggest that that's something that could also be done.
And for people who would like to know, why is it important for the continent to take part in this research?
Incredibly important question, and not everybody understands this. We know that there have been vaccines in the past where they've gone to licensure, where there was no participation from the African region. The HPV vaccine many people will have heard of, and that was the case there. But we also know that it's very important to do clinical trials in different populations and in our own populations, because each population is different, genetically different, but also we're exposed to different other background infections. In our setting, some people will be exposed, for example, to malaria. Other people will have HIV. So we want to know in our populations, is this vaccine going to be safe and effective? And when we compare to other populations around the world, do we see the same level of effectiveness everywhere? In some vaccines, that's not the case. We've seen some vaccines where the effectiveness does vary and the safety has varied. So it's terribly, terribly important that we as a continent participate in these trials.
And still keeping in that theme of research, let me bring in Dr. Borna Nyaoke-Anoke. Most COVID-19 cases in Africa have been either mild or moderate, and there is need for research to find the most effective ways of treating such cases. Tell us more about this. What is going on in that space? Dr. Nyaoke.
Thank you, Anne, for this opportunity. I'm going to give a small presentation. Next slide. So maybe just to start us off is to describe who exactly we are. Anne, you had already provided a very good introduction on what Drugs for Neglected Diseases Initiative is. We are a not-for-profit research and development organization, which was founded in 2003 by MSF, the World Health Organization, and 5 international research institutions, including our locally Kenya Medical Research Institute. We have offices in South and North America, in Europe and Asia, and we have 3 regional offices here in Africa, in the DRC, in Kinshasa, in South Africa, and here in Nairobi, Kenya. And within these offices, we've been able to work on a number of neglected tropical diseases, including human African trypanosomiasis, visceral leishmaniasis, mycetoma. We also look in neglected populations such as pediatric HIV, and we also work on antimicrobial resistance. And with the support of this, we've been able to discover, develop, and deliver treatments for neglected patients around the world. Through our work in these areas, we've been able to conduct state-of-the-art clinical trials in the most remote of areas. And with this, we assure that Africa is ready to be able to conduct some of this research that is required. DNDi has been able to provide treatments through the research that we've done within the continent, which are affordable and patient-friendly. And these have already saved millions of lives up to now. Next slide. So in our discussion today, a lot of the questions that have come or we've had up to now is, why exactly do we have quite mild infections in Africa? Why are we not seeing the fatalities that had been seen in the higher income countries? Are Africans immune to this disease? Is it really there? And these are the questions that keep on coming and that we need to answer at this particular time. This is a simple pie chart that just shows that almost 80% of the patients who get COVID-19 have mild symptoms or some are symptomatic. Then we have the 20% who have severe infections or extremely severe infections. Some of the hypotheses that have come about in terms of why exactly we have most of these mild infections, especially in Africa, is if we're to look at the immune system, changes that usually occur from the middle-aged to the older population, we see that they're more vulnerable to the reactive storm inflammation that usually harms the lungs and other organs, making them more susceptible. The median age in Africa is around 19 years, and almost 91% of the COVID-19 infections that have occurred in Africa have been in patients who are under the age of 60 years, which now lends to this having 80% of these patients who either have asymptomatic disease or have mild symptoms. Then we also look at most of the patients who have been vulnerable, and the fatalities that have been associated with being COVID-19 positive have been associated with our vulnerable populations, older populations as mentioned, and also patients who already have other comorbidities, patients with diabetes, hypertension, and kidney disease. We find that currently the infection was mostly within the urban areas where there's a lot of transportation occurring, or where we have our airports. But as Dr. Nkengasong has mentioned, now that we are having our restrictions being lifted, we're having the lockdowns being eased, we're having a lot of movement within our rural areas. Unfortunately, our rural areas in our villages, this is where our older population are. This is where we have patients with undetected non-communicable diseases. This is where we have high rates of malaria. If you look at Kenya, we had a recent outbreak of malaria within our Baringo County. We have our patients with malnutrition. At the same time, we have the patients with HIV who are not getting adequate treatment because of poor or under-resourced healthcare facilities. So we would expect at this particular time to have patients who are experiencing more severe forms of this disease. Next slide. This goes to a next slide where we're talking about the COVID-19 research in Africa. We have quite a number of questions, but we do not have the answers up to now. And for us to be able to get these answers, we need to conduct quite a lot of studies to be able to provide us with quality data. In the beginning of the year, though we did not have quite a number of cases within Africa, we can see we had very few studies being done in Africa. By September, we had quite an increase in the studies, but most of them based mostly in Egypt and South Africa, with few other studies which are scattered around the continent. Next slide. So the question is, why do we need to do this research in Africa? We are having mild patients. We are seeing 80% only who are mild or symptomatic, and only 20% who are having these severe cases. We have to look at our context in which we are. In Africa, we find that we have very low capacity to be able to have critical care management of our patients. We have limited hospital beds. We have the ICU capacities which can be reached at very fast speeds. And when we talk about critical care management, we are not talking about hospital beds alone. We're talking about the personnel. This is the ICU doctors, the critical care nurses, our physiotherapists, our nutritionists. Some of the things that we do not talk about is if we have a critical care nurse, as per the management guidelines, a critical care nurse can only take care of 2 to 3 patients at a particular time. So even if we have 100 beds at a particular hospital, if you only have 10 nurses, it means that hospital at that time can only conduct critical care management for only 20 to 30 of these patients. If you look at Kenya, as had been mentioned, in East Africa, the numbers have been increasing quite rapidly. We've been having days where we'd have almost 1,000 positive patients per day. If we go back to our pie chart, then it reminds us out of the 800, we have the 200 who have severe disease. These are patients who would require to have respiratory support, they would require mechanical ventilation, they would require this critical care management. At the same time, we have the 800 patients who are still progressing into the severe disease. So this comes back to our need within our African patients. We currently do not have any existing treatment for mild to moderate cases. As we are getting overwhelmed with the severe cases, we need to be able to have treatments in place that would prevent this progress of mild, moderate disease into severe disease, to prevent this overwhelming of our healthcare facilities. Prof. Rees has mentioned about having treatments in one place not being applicable within another place just because of clinical research that has been done. She has talked about vaccines, and this is also the case in therapeutics and drugs, which we have seen in the studies that we have done in DNDi, looking at Kalaza in India. Just because a clinical trial has been done in one particular population does not mean that it can be transferred to another population. Another point is we need to generate our own data that can be able to work in our specific low resource contexts. If we're able to develop a drug in a high income country, would it be applicable within our hospital settings? Would the mode of administration of this drug be applicable in a district hospital in the DRC? Those are the questions that we need to be able to have in place as we look for treatments and vaccines. Lastly, we have seen quite a number of times that local evidence does support faster adoption of new tools into policy. Thus, we need data from Africa that would support this policy change. As talked of quite a bit, we are afraid of having our health services overstretched. We are under-resourced within the continent, and having these numbers increase and not having treatments in place that would prevent severe disease from developing, then we would be overwhelmed. And if we're also to look at our population in terms of confinement is not an option for many of our people who depend on a daily wage to be able to feed their families. So for these patients who are not hospitalized, who are homebound and need to continue taking care of themselves and taking care of the families, we need to be able to provide a solution for them to prevent them, once infected, not to progress to a severe disease and not to make their condition worse. With all this, we see that we do require, please, previous slide. We do require large, well-conducted clinical trials so that we can be able to provide qualitative confirmatory data on our own people to support the guidelines on prevention and clinical management in our resource-constrained settings. Next slide. That is why DNDi and our partners will be soon launching the anti-COVID clinical trial across Africa. This is an open label, randomized, comparative, adaptive platform clinical trial that will test the safety and efficacy of treatments for patients at mild to moderate stages. We will be able to test 3 or more treatments in this adaptive study design, where we will look at repurposed drugs and new innovative drugs. Our objective is to respond to the urgent need to identify treatments that can be used to treat mild and moderate cases of COVID-19 to prevent them from progressing into severe disease. We are hoping to enroll more than 3,000 patients in 13 or more countries in Africa. Next slide. As we also look at treatments, therapeutics, we look at vaccines, we need to ensure as we work through this that we would be able to have access to these treatments. We need to ensure that the COVID-19 research results and affordable health tools would be able to reach everyone who needs them. So that is why we are calling on governments, donors, industry, and research communities to take these concrete steps that have been indicated here. We are hoping that DNDi, together with our partners, we will be able, after our clinical trials and our research, to work with local partners, the ministries of health across the continent, and other stakeholders within Africa, such as the Africa CDC, to ensure that all our population have access to these treatments. Thank you.
Thank you very much, Dr. Nyaoke, for that excellent presentation. And we are seeing so many people joining us, hundreds of people on Zoom, many more joining us on Facebook, YouTube, Twitter. Keep tweeting, hashtag Africa COVID-19. Just want to mention some of you who are online, Dr. Olawale Salami from Geneva, Switzerland. We have Franklin Brice Sung Ibala from Cameroon. We have Joel Duntio from Doctors Without Borders. We have Sharon Ann Lynch from the United States, Ashenafi Tesema, Jane Achan. Thank you so much for joining us. Keep sending those questions. Keep letting us know where you're joining us from, and we'll put the questions very shortly to our panelists. When COVID-19, the COVID-19 pandemic was declared, and when the first case was found here in Africa in February, some countries are already dealing with outbreaks of disease on the continent. I had just come back from the Democratic Republic of Congo that had been battling an Ebola outbreak, particularly in the eastern side of the country, an area that hadn't had an outbreak before. People there were struggling to deal with this, but then vaccines made a difference. I would just like to invite our next panelist, Professor Steve Ahuka. You were in charge of dealing with Ebola. What were some of the lessons that you carried on to dealing with COVID-19?
Yes, hello again to everybody, and many thanks to invite me to share this special moment, African experience. So as you said, DRC has a special, DRC has a special situation because it is the first country in the world to have two outbreaks. I mean, Ebola outbreaks before the pandemic, but also Ebola outbreak during as you know, during the last Ebola outbreak, DRC has many lessons, and some of the lessons that we have is how to engage community during the health crisis. So, I would like to say the difference between the two outbreaks according Congolese people behavior. Ebola, we have many misunderstanding and misinformation on Ebola. And we were thinking that during the COVID crisis, since it comes from the outside, we'll have less, but we have information on almost everything, including on vaccine. So the key lesson learned during Ebola outbreak should provide guidance for COVID management, including COVID vaccine. And some of the lessons are below. First is to develop an integrated communication strategy on surveillance, patient care, but also vaccination strategy. And these strategies should ensure clear understanding. For example, for the vaccination, understand the concept of eligibility, the concept of trial. They need to understand the side effects, and and so on. The second lesson is to ensure community engagement of leaders and political leaders. And this is very important before engaging the community, leaders and political leaders must be, and this situation can, avoid any misinformation during the crisis. Another lesson is to train healthcare workers so they have access to key resources and can answer to questions in the community. Because sometimes we notice that health workers write answers to the community, so they are, maintaining the cycle of resistance. One of the next lesson is to provide vaccine at routine healthcare facilities or locations that are closed. And what we are proud in DRC is to integrate social science, epidemiology, and service utilization analysis to understand the dynamic around perception and to inform, response strategies, and to change during the strategies according what the feedback that we are getting from the community. So some lesson, but I will be happy to discuss one of the aspect of the lesson that we have learned from Ebola crisis and we are now trying to adapt during COVID crisis. And as you know, right now we have 2 outbreaks: Ebola in the east and COVID in the country. So thank you.
Thank you very much, Professor Ahuka. I can see questions are coming in, so many of them. Thank you so much for participating. Keep tweeting #AfricaCovid19 and keep sending us your questions. We will put them now to our panelists. And there are those who are asking if the presentations will be available. This webinar is being recorded and it will be available after this live event. So first of all, let me just put some of the questions that have come in from our audience so far. So this one, we'll begin with a round of questions about vaccines. Here's a question from Alice Dexlow. Is the strategy to vaccinate everybody in Africa or to first define some target populations? What would they be? And would they be different in different parts of Africa, for example, in Central Africa? So either Professor Rees or Dr. Nkengasong can take that one. I'll just give a round of questions and then let our panelists answer. And another question, is it true that no Francophone African countries are hosting vaccine trials? If so, why? And there are several other questions coming in about vaccine development. There is Franklin Brice from Cameroon. This is a question specifically to Professor Rees. What are some of the main challenges you're currently facing in the COVID-19 vaccine development research, and how are these challenges being addressed? So if we could take that round of questions and then we can come back for more. Professor Rees, would you like to go first?
Thank you very much. Really good questions. So the first one, which of the populations would we do everybody or not? Well, there's 2 answers to that. First of all, we won't have enough vaccine to begin with to do the whole population. So we're going to get a limited amount of vaccine, and what we're arguing for through this a special financing mechanism called the COVAX facility is we're hoping that we get a lot of countries in the region to sign up to this COVAX facility, and in that way we will be able to guarantee a certain percentage of vaccine for each of the countries in the region. What we don't want to see is the richer countries, this is what happened with pandemic flu in 2009, that the richer countries basically bought out all the vaccine, and there was really very little left for our region. So the COVAX facility, the idea is that to begin with, there would be a small amount of vaccine available worldwide, and that would be divided up between countries. So that was the first part. But then the country would have to say, I've got enough vaccine, for example, for 10% of my population. Who am I going to give it to? So there's been a lot of work being done in the background with the World Health Organizations and groups like Gavi and CEPI looking at this and looking at the epidemiology. And obviously, when you look at this, you're saying, what am I trying to do with the vaccine? Am I trying to save lives? Am I trying to protect people who might be highly exposed, such as healthcare workers? Am I trying to stop or reduce transmission of the virus between people? At the moment, the discussion tends to focus, if you've got a limited amount of vaccine, on your frontline healthcare workers and some other frontline essential workers. But obviously, we want to protect our healthcare workers on the front line. They're going to be very exposed, potentially, to COVID-19 cases. If they wear PPE and they're fully protected, that should be okay. But we know that sometimes you're going to see patients and you won't even know that what you're dealing with at that point. So that exposure means that they're at risk. If they're at risk of themselves getting sick, taking it back into the community. But also, if we lose a lot of our healthcare workers through sickness and some dying, it means that all of our health services are then affected. So we're looking at healthcare workers, but then we'd also look at the groups who have high mortality. And in the richer parts of the world and in Africa, as you saw from that data, as you get older, your mortality goes up. So we would want to look then at older people. But we want to then also in our setting understand more, for example, about people living with HIV, because we have a unique challenge and problem with the numbers of people who live with HIV in our continent. So we would want to know, does the vaccine work in someone who's got HIV? Is it safe? And also, what is the risk? Is your risk higher if you're HIV positive of becoming sick? So there'll be lots of things that we would factor in as we make these decisions. But at the moment, with limited amounts of vaccine to begin with, many people are thinking about the frontline healthcare workers and other essential frontline workers who might also be highly exposed.
There are also related questions, but to do mostly with communities and communication. Here's a question from Joel Duntio from Doctors Without Borders. Social media in Africa is swamped with anti-vaccination messages. What is being done by the institutions to which our esteemed panelists belong to address the rising wave of anti-vaccination sentiment on the continent? There is also another question from Sisei Kasai. The question is, has there been evidence of reinfection with COVID-19 in Africa? With the first question, Dontio's question about social media and anti-vax, I would like to put this to Professor Ahuka, because this was a major issue that you dealt with when it came to Ebola, particularly in Eastern DRC, wasn't it? And please feel free to speak French, because we have many of our audiences following in French, and those of us who are listening in English can tap into the translation. Professor.
So you want me to speak in French?
If it pleases you to speak in French, those our audiences who are following in French would be very happy. Please go ahead.
Okay.
In what language you would like to speak.
Bon, oui. Je crois que nous avons une épidémie d'Ebola et présentement encore, nous avons une épidémie de la poliomyélite.
Polio epidemics also. And we are giving a vaccination, and we have some resistance cases because we confused the normal vaccination and COVID vaccine. Now, in Africa, we don't believe.
Les gens ne sont pas informés qu'il y a les mêmes efforts de vaccination
People
ailleurs.
are not informed that there are the same efforts in terms of vaccination in other countries. In West, okay, we believe that maybe they should start with the West and not with Africa. That is what we believe. One of the lessons that we need good information, and starting with the leaders, political leaders, who should give reliable information so that we can be able to understand. For example, regarding the epidemic, the outbreak of Ebola, there was a problem of the communication strategy. And then community leaders and political leaders should give good information. In Mbandaka outbreak, we didn't have problems because the communication was clear there.
Merci beaucoup, Professor Ahuka. Thank you very much for that. And for those of you who are following in English, I hope you didn't miss that. There's an interpretation button at the bottom of the screen. You can just click on it to get to continue listening in English. Another round of questions. This one is from Sharon Lynch from the USA. This one is directed to Dr. Nkengasong. Can you speak about the supply challenges with PCR tests? And she gives specifics about what is allocated to Africa and what can be done to address that. Of course, in your presentation, you had touched on PACT and how you have improved the procurement of these diagnostics.
Yes, absolutely. And I think what I said during the presentation is valid, that we are better prepared today than we were 10 months ago. 10 months ago, it was almost impossible to have access to diagnostics, even if you had the money. But today, with a platform, the AMSP.Africa, any country in Africa can actually go in there and procure diagnostics as well as commodities to respond to COVID-19. And as I also indicated, with WHO, World Health Organization, we begin to distribute the antigen test, which is going to also be as good as the PCR test itself. So I think the issues that we had 10 months ago for diagnostics have changed a lot. I think the greatest need we have now is to decentralize the testing as quickly as possible and also continue to scale it up, okay, so that as we ease the lockdown on the economy, if there are hotspots, then we can pick them up very quickly and then do what, apply the public health measures there, which is the contact tracing, isolation, quarantine. That's what we need to do now. So I think a short answer to your question is, yeah, we have plenty of avenues to get diagnostic tests to the countries now.
Fantastic. And while you're still speaking, there was a question about vaccines and how they are going to be allocated. Where are we at the moment with regard to ensuring that Africans will get vaccines? They will not be at the back of the queue.
We are working as the African Union Commission and Africa CDC through multiple channels. First is that we fully support the COVAX facility in Geneva, coordinated by the World Health Organization, WHO, and Gavi and CEPI. We also recognize that we have to take our own destiny in our hands, that is as a continent, and develop a mechanism that will ensure that we raise enough funding in order to support vaccine acquisition, either through supplementary COVAX allocation or working with other groups like the Serum Institute in India. So as we speak, that discussion is actually going on And we really hope that with Afro-Exim Bank is ready to allocate up to about $5 billion if the continent mobilizes itself around and begin to generate using their special drawing rights to raise up to about 1.8 billion, then the bank can leverage that up to $5 billion. I think that would be a significant amount of funding that would be available on the continent to continue to work in the vaccine area. We are also looking at vaccines from our definition of actually timely access and equity is that the vaccine has to be, we have to have the money to buy it. That is one. Second is that we have to strengthen delivery systems. And thirdly is that we need to begin to think of local manufacturing on the continent. Those are the three ingredients that will make us pleased that we can actually, that we can effectively talk about timely access and equity in vaccines distribution as far as Africa is concerned. Over.
Thank you very much. And there are many questions coming in, particularly on vaccines and research. This question is from Miriam, directed to Professor Rees and Dr. Nyaoke. What about research on pregnant women? Are we lacking research on pregnant women and COVID-19? And will they be included in Anticov? Professor Rees, would you like to go first?
It's a really, really good question because, for example, I just mentioned that a priority group that we might want to immunize first would be healthcare workers. And we know in our region, the majority of these are going to be female, and many of them are going to be of a childbearing age. So the answer is this is getting a lot of attention, including through the WHO structures that are looking at all the vaccines. Now, many developers will be cautious about going straight into pregnant women when you're doing early phases of developing a vaccine, and even when you're doing these large efficacy trials. But because in many of these studies, in these phase 3 studies, we're going to have as many as 30,000 participants, we also know that inevitably, even if you try and exclude women who are pregnant, there will be some women who didn't know or chose not to disclose. If that's the case, one of the things that we will certainly do in all of these studies is make sure that those women are closely followed up. The second thing, though, is that the vaccines that are in development have different types of technology. And some of the technologies are tried and tested and known to be safe in pregnant women, and some are very, very novel. So for those that are tried and tested and we've used in different ways for different vaccines, that same technology, we're going to be more confident about going in as soon as we can to evaluate safety and effectiveness, but safety in particular in pregnant women. Others of the more novel and things like live attenuated vaccines, but live vaccines people will be more cautious about. But it's certainly extremely high on the agenda, and we're trying to see how we can integrate for all the different vaccines pregnant women into that development process at an appropriate time.
Thank you very much, Professor Rees. And Dr. Nyaoke, while you answer the question on pregnant women and COVID-19, here is another one for you. What lessons can we take forward from this continental effort to study repurposed drugs in phase 3 adaptive trials that could be useful in strengthening Africa's capacity for preclinical and early phase drug development in future? That's from Olawale Salami. Dr. Nyaoke?
Thank you, Anne. So for the first one, for the pregnant women, Prof. Rees has adequately answered this, which would also be applicable to our therapeutics and also the drugs that we would be developing. When we're trying out any new drugs, any new innovative drugs, we tend to try to avoid the pregnant women as we try to find out the safety of the drugs. But as we look at other drugs which we are repurposing for this, if they have been used in pregnant women before, then it would be applicable within the clinical trial. But this would be done within phases just to ensure that these pregnant women are not put in any situation or within a clinical trial that would prove to be a danger to the fetuses at this particular time. So as we look at the different drugs that we are going to be applying within the Anti-COVID trial or within any other drug trial, we would put this in consideration because we do understand that pregnant women, while during pregnancy, you have your immunity suppressed, so you are actually more bound to progress to severe disease once you're infected. For the second question, yes, we have been looking at in terms of our collaborations within the continent, what we can do to be able to increase our clinical trial capacity within the continent. And within the Anti-COVID trial that I'd mentioned that we are having almost 13 or more countries, it would help us to be able to conduct more trials in the early development or phase 1 to 2 clinical trials, because we realize that most of the trials within the continent have been quite fragmented. We see that working together, putting our resources together, having investigators, having our clinical trial lists in different countries who have different capacities coming together makes conducting a clinical trial and setting it up much easier. So we do hope these practical experiences that we are having within this pandemic and as we conduct these trials would help us increase our resources to be able to conduct better and more trials in the future.
Thank you very much, Dr. Nyaoke. Here's a very important question from Professor Ahuka. What strategies should be implemented to convince the community of the existence of this pandemic, especially in rural areas? How did you deal with that, particularly in Eastern DRC? I keep going there because I remember going to the communities there, and months into the outbreak, there are still those who are convinced that Ebola was a foreign thing, it did not exist. And those of us who are going in and driving around because of the roads in 4x4s, they were calling those 4x4s Ebola. So the Ebola was a foreign thing for them. So what did you do to convince the communities of that existence, and how can we use that knowledge in dealing with COVID-19? Professor Ahuka, please feel free
merci beaucoup.
in
Thank
French.
you very much.
For our audiences, you can go to the bottom of your page and click on interpretation to continue listening in English.
OK. Oui, merci beaucoup pour la question.
Thank you very much for that question. Exactly. We created some analysis in social science, epidemiology, which was used in the community to collect the perception and to adapt to strategies regarding the community, to know the level of knowledge from the community, the level of the understanding misinformation, and adapt the communication to fill in those gaps. That is what helped us to combat the resistance. We use the same strategy to convince the community, and we use the same experience of Ebola. That is very important because in Africa we import the strategies which are not, in many cases, which come from the West, which are not adapted to the context. Now our experience helped us to have every time the feedback from the community and to adapt the strategy. For example, the strategy of testing, isolate people when the disease is very strong. So we have to convince the people that we have to test. We need to make the community understand the gravity of the situation, because sometimes we test the people who are asymptomatic, but now that helps us. That is every time we have to inquire so that we understand the perception of the community and to adapt our intervention and strategies to the reality of the community.
Merci beaucoup, Professor. Here's another question for Dr. Nkengasong. Will the new rapid test require technical personnel or can it be administered even by lower cadre trained staff to carry it out? And how long does the rapid test take to give the result? And apart from that, there's also a question from Sise Kasai that had been asked earlier. Has there been evidence of reinfection with COVID-19 in Africa? Dr. Nkengasong.
Yeah, the antigen test is definitely easy to use. I would rather say easier to use than the PCR test. It will take about 30 minutes, and we at Africa CDC have been working with other partners to provide training for the use of tests. I mean, so I think that is going to definitely be easier and would allow us to decentralize the testing to a lower level, to a regional and sub-regional level. But that will also be accompanied by training and also quality assurance as well. With respect to reinfection, I think only prospective studies will allow us to know if reinfection can occur. And again, these are extremely important studies that will teach us as to how the immune system can react to this virus. So in other words, if somebody is infected and they develop antibodies and with time, or what you call T-cell immunity, can the person be reinfected over time? I guess only prospective analysis and well-designed studies will teach us that. So for now, we just don't know. I mean, we don't know if that is possible or not possible.
Thank you very much, Dr. Nkengasong. I'll just give the last round of questions as we bring this to a close. These questions were asked even before the webinar started, so it would be very unfair to leave them out. Ms. Gebu Silamso Asres from the University of Gondar in Ethiopia asked, the infection rate is very low despite what I see as the improper use of masks, no physical distancing, and unavailability of hand sanitizers and hand washing. On the other hand, there are more deaths because of HIV, TB, malaria, and other infectious diseases. Can we conclude that COVID-19 should not be an issue in Africa and people should rather concentrate on the control and prevention of other diseases? The next question is from Jane Mokami in Kenya. Various factors have been put forward as to why Africa has not had such a high COVID-19 death rate compared to other regions. And she's asking, is there any ongoing study or research being undertaken to ascertain this, and which factors seem plausible? And the final question is about the request put in by South Africa and India to the World Trade Organization to loosen intellectual property restrictions related to COVID-19 vaccines. Will there be a successful approach will this be a successful approach in increasing access to vaccines? So those three questions, any of our panelists can take them. Let's begin with Professor Rees, and then Dr. Nyaoke, and then Professor Ahuka, and finally Dr. Nkengasong as we close.
Thank you. Well, I'll take then the first one. You know, should we just say that this isn't an issue? Absolutely not. If you saw the figures that were so nicely shown of, you know, that 20% of people will have moderate to severe illness, of whom 5% will have very severe illness, and some of those will die. It's not that we don't have any mortality, we do have mortality. And we are seeing the same patterns of mortality increasing with older people and with these comorbidities. Some of those will die. Now, if we just let this virus do what it wants to do and sweep through, there will be tens of millions of people infected. And when you have those numbers, it means you're going to have a lot of really sick people and a lot of deaths. And the economies are going to suffer. They are suffering with lockdowns, we all agree that, and we want to have the lightest touch of a lockdown that works and restrictions that really work. But if you just let this sweep through, the burden that's going to impose on our health services would just be overwhelming. And in terms of, why is it, as we've said, it could be the demographics, our younger age group, but there are other things that are also under investigation. For example, is it that we are using other vaccines that might have a more general sort of immune boosting effect that could be giving some sort of protection? People are looking at BCG, the oral poliovirus vaccine, and the measles, mumps, rubella vaccine. So we're looking at other things that we might be doing in our communities that might be giving us a degree of protection that perhaps we're not seeing in the same way in other communities, say in richer countries which don't have the same pattern of vaccine use as we do. So that's the kind of thing that we are looking at. But certainly, do we have to look at HIV and TB and malaria? Absolutely, yes, we do. Completely right. But do we let riot? No, because what we've already seen with HIV and TB is that the numbers of people who've dropped off treatment, the number of TB cases who we've now neglected to diagnose has shot up because of the impact of COVID-19 on health services. So that is not an option for this region. Thank you.
Thank you very much, Professor. And just 30 seconds each for the remaining panelists. Dr. Nyaoke, just summarize your answer and your closing remarks.
Thank you, Anne. So just to summarize is exactly what Prof. Rees has mentioned in terms of definitely we need to look at COVID-19 in Africa. We do not have all the answers. We need to do more investigations and more research so as to prevent any death is a death that can be prevented at this particular time. If you remember Professor Nkengasong's graph where we're looking at the inverse graphs between HIV and COVID, we do not know where exactly we are. We do not know how many waves. We do not know where our peak is, and these answers should not be answered by fatalities that we're experiencing within the countries. So if we are able to get the answers right now, if we're able to find the treatments, if we're able to get a vaccine in place, then this is definitely should be a priority. Working in neglected tropical diseases, we are well aware that quite a number of diseases in which people are dying from, and COVID-19 is a pandemic at this time, and that does not mean that we should ignore any endemic diseases, but they should be put as a priority with each other.
Thank you very much, Dr. Nyaoke. And very briefly, Professor Ahuka.
Merci. Oui, merci beaucoup. Je pense que, comme les autres collègues ont dit,
thank you very much. As other colleagues have said, Africa has been oriented to try to respond to COVID-19 during these months. Now, there are some stability because of the efforts which were made to try to respond. And in DRC, we started by knowing to study the seropositivity of people before trying to understand the reason why Africans are not very vulnerable to COVID-19. But now there are some questions which can help for other diseases. Thank you very much.
And finally, Dr. John Nkengasong, your closing comments, please.
Yeah, let me, I think the comments from my colleagues, Helen and Steve, they make my job easier. I think that we need to continue to be extremely cautious with this virus. We've done well. The data is there to show, as I indicated earlier, I've actually now undertaken a country visit to really encourage them for what they've done, but also to be sure that we raise a warning, very early warning that we are not out of the wood yet, and that this virus spreads very quickly and it can actually deceive you to believing that you've conquered it, and then it will come back very fiercely. So I think a message to the entire continent is that no complacency, no fatigue, because I see that the people are moving without masks. I think we have to mask as much as possible. That is the vaccine. The effective vaccine that we have now in our hands is the mask. I think we have to use them in a sustained manner. And I'll call on governments in Africa to support the population, especially the vulnerable, so that they can afford the mask. It may look very simple, but if someone is living with less than $1.9 a day, and they have to struggle between that and eating, feeding their children, and buying a mask, they may neglect that. So I really call on governments in Africa to think of subsidizing the population with a mask and engage the community in a manner that we used for the HIV response, so that the community can actually own this response, engage in the response, and show leadership in the response. But the government has to do its part by subsidizing even basic things like masks. So again, let's take this virus very seriously. We fought a very good fight in the first part of it, but the battle is not over. It's far from over. Vaccines will be there for sure, but it will take long before we vaccinate the populations that will provide us that safety net. The world has never vaccinated over 500 million people in a year, and that is what we ought to put systems in place that will be able to roll out vaccines to a large number and millions of people in a year. So I thank you for the opportunity to contribute to this very important program.
Thank you very much, Dr. Nkengasong, for that very important message all across the continent. And this is a very important conversation, and we really thank everyone who's been following us on our various platforms on Facebook, Twitter. Keep tweeting, #AfricaCovid-19. Thank you to those following on YouTube and even here on Zoom. We're just coming to the close of this webinar. I've just been given a few more minutes by the organizers, and I would like to invite somebody very important, the director of the DNDi Africa Regional Office, Dr. Monique Wasuna, to give us some closing remarks.
Thank you very much, Anne. Good morning, good afternoon, good evening to you all from wherever in the world that you have joined this Africa webinar. Mine is just a pleasant and humble task of giving a vote of thanks. So I would like to start by saying that it was really a very successful webinar. We got to discuss very many issues, and you know, we have very many attendees on the various digital platforms that we have, as Anne has already alluded. So thank you all for making this a memorable day and for making this happen. A very big thank you to our moderator, Anne Soy, Deputy Africa Editor and Senior Correspondent for BBC. Well done, Anne. We appreciate you. You know, it was just smooth and I enjoyed everything. And you had such a nice smile and it really went on very well. So thank you, thank you, thank you. We would like to thank very much Dr. John Nkengasong, Director, Africa CDC, for the excellent keynote address. John, you are an inspiration to me and many, many, many other people in Africa. We have achieved a lot as a continent due to your leadership. Well done, John. I think the first time that we interacted was at the BBC interview when both yourself and I were discussing this. So you did extremely well then and have done extremely well today. And with the concluding punching points to our communities, and I hope that people were listening very much to you, because no complacency, no fatigue, and political support, you know, help the people to buy the masks, the political leadership, please. So thank you very much, John, for your words of wisdom. I also thank Professor Helen Rees, Executive Director with Reproductive Health and HIV Institute, South Africa. As you're already aware, the voices of the African women and African scientists are still in the minority globally. We are very proud to have your contribution in making our voices to be heard, and the work that you're doing currently in terms of vaccines. Well done. Now to our own Dr. Borna Nyaoke, Clinical Project Manager and Medical Manager, Drugs for Neglected Diseases Initiative. Thank you very much, Borna. Borna, you are an example of the young people in Africa who put their heart and soul in what they do. Our future in Africa is with your generation and others after you. As your director, I'm extremely proud of you and well done, Borna. Professor Steve Ahuka, Senior Researcher at the National Institute of Biomedical Research and the Incident Manager for COVID-19 response and the 10th Ebola outbreak in DRC. Thank you for your vast experience in Ebola that you are currently repurposing for COVID-19. This is what we need in Africa, is to move, for us to move forward. We need experienced hands like yours. So well done. So repurposing is not just for drugs, it can also be for experience. You have a Ebola experience, you learn something there, bring it to COVID, and this is what Africa needs. Now to all of you, the panelists, again, thank you for sharing the lessons that the world can learn from Africa and how we can collectively address the COVID pandemic with quick responses from from governments and leadership from institutions such as Africa CDC. We've been able to respond to the pandemic, but we are not yet out of the woods, as you heard John say. We have to continue to work together, carry out our research so that we have credible data that is specific to us, just like what Borna was telling us. And we need to engage communities. You heard Steve say that, and develop relevant policies if we are to overcome this pandemic. So it's always the invisible people behind the scenes who work day and night to make such events successful. So I really want to appreciate all the global DNDi and the COVID-19 Clinical Research Coalition, together with the DNDi offices in New York, in Geneva, South Africa, DRC Congo, and the Nairobi office. A very big thank you to you all. A job really, really well done. Ladies and gentlemen, on behalf of DNDi and the COVID-19 Clinical Research Coalition, I'd like to thank you all for attending our webinar today. We have participants from all over the world who have made this a very interactive session. This webinar has been coordinated by our offices in Kenya, South Africa, DRC, and North America, and Geneva. So let us keep these discussions going as we close this webinar. I invite you to learn more about our work on COVID-19 through our digital platforms, and really let us forge partnerships going ahead. No one can do this together. In Africa, we need each other. If we have to go further, we have to go together. Thank you, and over to you, Anne. It was a pleasure.
Thank you very much, Dr. Wasuna. To our panelists, thank you for making time and for the excellent contributions. To our audience, thank you for asking all those questions. We couldn't answer all of them in the space of time that we had, but let the conversation continue, as Dr. Wasuna says. And as we leave, we say our goodbyes. We leave you with this video. Thank you again for joining us.